Good evening. Tonight's show is going to be very entertaining. Dr. Tim Weyrich is here for your enjoyment. Stay tuned. Good evening. Tonight's show is Dr. Tim Weyrich, and we're going to talk about urological distress. Tim, welcome to the show.
Thank you, Gene, once again. It's always good to be here.
It's always an entertaining show, and tonight we're going to start off the topics with kidney stones.
Not fun.
No,
Ask
especially if you
anybody
have
that's
one.
had them. Nobody likes those, and the wonderful questions are, how do you treat them, and what's the best way, most importantly, to prevent them?
Excellent.
So let's talk a little bit about treatment. A lot of varieties. Now, the good part, Gene, and I see you've done your research,
I've done my research tonight.
The majority of stones will encouragingly pass on their own. They are extremely painful. Many trips to the urologist and emergency room. But the good part of stones is they will eventually pass out of the urinary tract on their own if they do not have a variety of options. Shockwave lithotripsy, scopes in the urinary tract, and encouragingly in this day and age, rarely do you need any type of open surgical procedure. But literally they can be very painful, morbid, and cause a lot of difficult problems.
Okay, does any one particular person get them more than anyone else?
Typically folks that are at high risk are those with a family history.
Okay.
They have a tendency to have what's called lithogenic or stone-forming urine, so people with family histories have to do their due diligence on drinking. And believe it or not, Gene, this isn't coffee.
This
This
water.
is actual fine McMurray water.
Right.
They have to drink water. That's actually the mainstay of stone treatment.
Okay. Are there any medicines, because we always hear the medicines, are there any medicines that we have to watch out for if the doctor puts us on?
Typically for causing stones, there's not a lot of medications that are really going to
Okay.
cause stones. I mean, some medicines that are used, such as diuretics, to rid the body of water, actually can help with stones. Other ones may increase the risk. But in the general population, stones aren't going to be caused per se from medication.
Okay.
The majority of people that get into problems, Gene, with stones just don't drink enough water. Probably the average American is chronically dehydrated. You know, they drink pop, they drink coffee, they drink tea, all of which are agents that don't hydrate you. Water, juices, lemonade is an excellent fluid, Kool-Aid are all good agents to help prevent kidney stones. There are medicines available to help prevent them, but when you really talk to people, the majority of people don't want to go on pills lifelong for them unless they really become numerous and cause a lot of problems.
Okay. Tonight's guest, Dr. Tim Weyrich. We're talking tonight on any urological condition you want. Tim's a board-certified urologist here in the area, taking care of close family members, and I'm still trying to avoid him, fortunately.
I'm working on it, though, Gene. You're getting close to that magical age.
I'm getting up there now. As a famous guy once said on late night TV a long time ago, on this paper is everything you ever wanted to know about urinary incontinence.
There you go.
This paper right here, we've garnered this from our trusty staff, and we're going to talk about urinary incontinence in women.
There you go. We'll do that next.
Okay.
When you classify urinary incontinence in women, Gene, basically you're looking at two different types of incontinence. Basically, what you see across the advertisements in this day and age is one of the classifications of urge incontinence. Boy, when I got to go, I have to go. And that can be, particularly as women age, associated with the inability to hold it, and basically the bladder just goes and you leak.
Okay.
The medicines you see advertised are very effective medicines. They're not 100% effective, but great medicines. Now, the key element of that is the second main issue of incontinence in women, and that is stress urinary incontinence. Now, stress, not emotional stress like your wife has to deal with married to you, but actual physical, like picking up something, coughing and sneezing, which with aging could be associated with childbirth. So there are two different types of incontinence which are treated totally different. Now, of course, in medicine, we have to confuse everything. There's also a mixed where they can have both components of both a stress and an urge component. Let's talk about stress incontinence first. Typically associated with childbearing, dropping in the bladder, and doing things when you're actually picking up. The majority of women with stress incontinence are typically mild. It can be handled with weight control, Kegel exercises, in some women pessaries, and finally surgical options can be discussed with either a urologist or a gynecologist.
Okay.
Urge incontinence is a totally different ball of wax, if you will. Basically, again, when I have to go, I have to go. And what you have to understand, Gene, as the urinary tract changes as we age, both in men and women, urgency is common. Most people, when you sit down and talk to women, can handle it with no medications, but the medicines will work for severe cases. Again, not 100%.
Okay. Once you start these medicines, are these things that you have to take every day? Or?
Yes, typically it's not a one-time fix. Now, as I alluded to with surgical incontinence or stress incontinence, a lot of times you get the surgery done, it may resolve the problem and you never have it again.
Okay.
But the medical therapy for typical urge incontinence is a lifelong ordeal.
Okay. The people that get these conditions, do they have to have had children?
Not necessarily. Obviously, in urge incontinence, it can just be aging. Other things can worsen that. People with Parkinson's, any neurologic problem, diabetes, the diuretics we mentioned earlier.
Okay.
Any of those can set a scenario where they have more urgency, i.e. when I have to go, and urge incontinence. But childbearing in and of itself will not necessarily create that as it will with stress incontinence.
We love to beat up the smokers on this show. Is there any association with smoking?
Not really. I think the only thing is with smoking, just as a caveat on this, if you will, smoking does increase your risk of bladder cancer. It's the #1 cause of bladder cancer in the United States today. Some patients with bladder cancer can present with urgency, frequency, and burning, and that's part of a mixed bag. But just to answer that question, smoking typically will not cause that.
Okay. Again, tonight's guest is Dr. Tim Weyrich. He's a board-certified urologist, and we're talking about urological conditions. The medicines that you talk of, are there any particular ones that are different, or are these the medicines?
Well, the medicines, there are a variety of medicines that you'll see on TV. The original really medicine for this, going way back, if not one of the originals, was a medicine called ditropan or oxybutynin. Right now, if you watch TV, if you pick up a surgical or a urologic book, you'll see medicines such as Vesicare, Enablex, Sanctura. So there's a variety. I think right now there's about 6 brand names out there. They're all good medicines, and the magical question is which one works better, whichever one works better in that patient.
Okay.
You know, like we do in a lot of things, find what works for that patient. And there are some patients that it's that severe, nothing works.
Okay.
There are, and I will say this, there are some surgical procedures for urge incontinence, implantation of devices, augmentations of bladder, but you're looking at typically pretty severe cases that are refractory to all other medicines and treatment modalities, but still disabling enough to the patient they want to pursue an aggressive treatment.
Okay, so rather than just saying 10, 15, 20 years ago when they just said you have to live with this, go get some.
Yeah, now there's a lot more options
Okay.
available. The nice part is, again, to reiterate, the majority of people with overactive bladder, once they understand what's going on and some of the precipitating events, don't need anything. Just,
Okay.
as I said in my coffee table book, it's my patients in the bathrooms of southwestern Pennsylvania.
Right.
They know where all the bathrooms are.
All right, I got you. When you have, are any of these, you talked about pregnancy, is this something that a lot of pregnant women get, or is this after the pregnancy, so to speak?
Urgency and urge incontinence can occur with the pregnancy due to fluid changes. But also understand you have a growing mass, if you will, for no other way to say it, in the uterus, which is then putting pressure on the bladder. So that in and of itself will cause urgency, frequency, and possibly urge incontinence. Obviously, common sense says you're not going to do any therapy at that time. You're going to allow the baby to be born. And again, encouragingly, the majority of those symptoms will resolve.
Okay. Are there any tests that you do either in the office or at the hospital that would help make a
Well, a
diagnosis?
standard, basically a history, but when you're getting into specific testing, there are what are called urodynamics, where we study pressures in the bladder. That's very helpful, particularly if we're trying to separate an urge and stress component. But the majority of people don't need a lot of aggressive testing. Occasionally, obviously, a pelvic exam, and occasionally a simple cystoscopy, which is a small scope in the bladder, all of which can be done comfortably in an office.
Okay. We talked about women. Is there any subject in men you'd like to go over before we move it along?
Well, you know, incontinence in men, let's just briefly touch on that, if you will. Incontinence in men typically is much less common than in women, primarily due to anatomy. Obviously, childbearing is not an issue. So incontinence, when men come in and have true incontinence, urologically that's much more concerning because that may be associated with problems with their prostate and blockage. So that's much more worrisome when that's brought up in a urologist office versus a woman.
Okay. Men, when they have to get up and go to the bathroom at night, is that something that's abnormal? Do we see that as we get older? Is it something they need to see you with? Or do they have to take care of business even
Well,
before
great
seeing
question. Understand, we mentioned earlier, changes that occur in the dynamic urinary system. Basically, what I mean by that is as all of us age, both men and women, we will have more frequency, urgency, getting up at night, smaller streams, basically symptoms that are just normal associated with the aging urinary tract. For a man, as he ages, it is common, and for a woman to a degree too, without a prostate, you'll get up at night to void. As they age, they're going to get up more, irrespective of their prostate. So a normal beginning in their 40s and 50s for a guy to get up once at night is not uncommon. Now, a 50-year-old getting up 5 or 6 times at night, that's worrisome. An 80-year-old getting up 2 or 3 times is not uncommon. It goes back to once the patients understand what's going on, are those symptoms troubling enough to go on medication for? And again, that's a commitment to medicine that you have to stay on.
Okay. So if somebody has those problems, though, you'd suggest they come see you or the family doctor?
Well, I think the family doc, and you know, the family doctor understands what's going on, and are there signs or problems that then they need to be, that I need to see them? You
Okay.
know, I mean, are there things, or is it just the normal 80-year-old gentleman or lady that gets up once or twice at night that really has no other problems?
Okay. Let's switch topics and talk about urinary tract infections.
Okay.
Tell me I would assume women get more urinary tract infections.
Anatomically, they're much greater risk. And what I always tell women is the route, if you would, for urinary tract infections in women is normal bacteria in the vagina ascend up into the bladder and colonize it. That doesn't mean anything is wrong. That doesn't mean they're going to have kidney or bladder problems. Family history has some bearing where women coming from parents, or excuse me, mothers with recurring UTIs are a little more at risk. Some key elements to try to prevent that, as in any urologic scenario, lots of good fluids, void regular, void after intercourse, and proper hygiene. The good part is, again, there's no serious sequelae. The bad part is you just can't fix it. Most of the women that walk in my office, once they understand nothing bad's going on, encouragingly, I have them self-treat their own infections. They know their symptoms, they understand it, they have a prescription, they just take it. And they love that because they don't have to worry about calling anybody. They're competent enough to treat their own infections safely and effectively.
Okay. Should we worry if we see a young adolescent getting a urinary tract infection?
Typically not. If you go back to our literature, we worry about children that get them, and we work them up to make sure they don't have what's called reflux, where the urine goes back into the tubes and possibly lead to scarring of the kidney. Very uncommon.
Okay.
Typically an adolescent with no other mitigating problems, we don't panic too much about that.
Okay. How about men? We talked about women with urinary tract. How about
Now,
men
man,
with
again,
urinary
it's
tract
funny.
infection?
Once again, we look at it differently, not because we're biased, but understand men with recurring infections typically point to a more serious problem with obstruction of their prostate, which means that it's more significant than just getting up 1 or 2 times at night. So guys, not a man that just comes in with an infection, but recurring UTIs in a man, we look at and potentially treat a little more aggressively because of the presence of the prostate.
Okay. Let's touch a little bit about prostate cancer.
Sure.
Since we're covering the
It's
gamut
getting to be
tonight.
pretty big.
Right.
As we age, it's getting bigger.
Okay.
Yeah.
Is it true that if the man lives long enough, he's going to get prostate cancer?
Yeah, if you look at an old statistic that we always had urologically, is if you took 100 men at the age of 80 in a room and they died for a variety of reasons, and you actually examined their prostate microscopically, 80% of those men microscopically had evidence of cancer. Obviously, that's not what is killing or causing the demise of those men. The hard part is when you're dealing with cancer, and you know this since you see a lot of it from a variety of sources, including the colon, is trying to predict what that cancer will do and the biological aggressiveness of that cancer in that patient. And the tough part right now urologically is not the young man with prostate cancer. It's as they begin to get into a little bit older ages, what are they like physiologically? What are they like chronologically? And with the data in front of you, do you think, to the best of your ability, that that disease will become significant in their lifetime? Like I always tell patients, you don't want the treatment to be worse than the potential problem. I have guys that come in the office that my gut feeling is they have prostate cancer, but we really don't aggressively pursue it because the odds are statistically that the cancer will outlive them.
Okay.
That, you know, there's other mitigating problems where they're going to probably demise of something else. So why put them through the stress and the concern of that?
Okay. At Canonsburg, I saw you just recently started a new project.
Yeah, we're doing brachytherapy with Dr. Mark Trombetta from Allegheny.
Okay.
Basically, brachytherapy, or radioactive seeds as they're known in the lay population, is under an anesthetic using ultrasound guidance. We place needles followed by radioactive prostate seeds into the gland. Basically what happens is the seeds are delivering a radiation dose to the prostate, killing the cancer. Outpatient, you don't have to come in the hospital, one treatment, you're done. Really good data has really evolved. When I was originally at the university, we actually used to put the seeds in through an incision. I hate using the term blindly, but in those, you know, we put them in, but not nearly to the science that it is now. And it's really evolved into a nice treatment for the right patient.
Okay. And that, again, is state-of-the-art treatment?
Yeah, the brachytherapy treatments are really, they've really done well. The nice part you know, you have basically 3 treatment modalities that are the mainstay for prostate cancer: surgical removal, brachytherapy of the seeds, or external beam, which is, you know, every day for 8 weeks. The nice part of the brachytherapy over the external beam for the right patient is you go and you get it done and you're not going to the radiation department, you know, for 8 straight weeks.
Right.
A lot of people don't mind, and that's a very good modality. But, you know, for some, they want to go in and be done with it.
Okay, I guess if you're sitting out there in TV land, you're thinking, well, they put those seeds in, do they take them out?
No.
Okay.
The only thing you have to worry about is, you know, a couple key issues. It's a large radiation dose at one time, and you always have to talk to your radiation doc about the risk associated with bladder and rectal irritability due to the radiation dose. The other thing you have to be a little cognizant of, because you have a higher radiation dose, is watching very young children, like grandchildren sitting on your lap, you know, people that are rapidly growing. Now, I'm from West Virginia, and radiation exposure really has no effect on us. But, you know, to young kids, it could be a problem. So you have to be a little careful with that.
Ian Coulter, move aside. Here comes
That's
Tim
right.
Weyrich. We'll see you on Fox and News tomorrow night then, I guess.
Exactly.
Oh, we forgot our weekly Pirate update.
Do we have a Pirate? Are they playing?
They tied today,
Oh.
I believe 8-8.
How do you tie in baseball?
I'm not really sure, but that's probably about as good as it's going to get for them this year. Although everyone's quite encouraged. What do you think, Kev?
I hope they do.
Okay.
The Penguins are playing well.
Kev thinks it's okay.
Okay.
Okay, back to prostate. We're going to talk, urological, everything we wanted to know was
We're
in
right
this,
there.
but
We're
we skipped
getting
over
it.
there
We're
a
doing-
little bit. We did.
We're doing pretty well. We talked about our stones. We talked about our incontinence. What else?
I don't know. We got some more time.
Erectile dysfunction.
Oh,
You want to do
that's-
erectile dysfunction?
Yeah,
it's a hot
perfect.
topic
That's
today.
a perfect topic.
Viagra, Cialis, Levitra medication.
We see these things all the time.
They're
Now,
constantly.
careful
You have,
now. This
yeah,
is a
that's right.
family show, so you have to be careful.
Very good oral therapies for erectile dysfunction. There's other options available. It doesn't work in everyone.
How's Bob Dole doing? Because I haven't
Bob's
seen him
doing
on
well.
TV.
He's
I
doing
haven't
well.
seen him on
His
TV
arm's
much.
still a little, but he's okay.
Oh, jeez.
Got you on that one,
Ann
didn't I?
Coulter, move aside, baby. Here comes
On
Tim Weyrich.
the only important thing you always have to realize with the medications are if you take nitroglycerin or nitrates for your heart, you cannot take those pills in conjunction.
Well, did you
them.
see the movie As Good as It Gets?
Oh, it's the
with Jack
best. Yeah, with
Nicholson?
Jack Nicholson. we went
That
to the
just
emergency
teaches you right there. That teaches America all you need to know
Can't
about
do that.
nitroglycerin
That's
and
bad
Viagra.
juju. Other modalities are still available. There's still vacuum devices, injection therapy, suppositories, and prosthesis, all of which are effective, but the mainstay anymore with the pills are the oral medications. And they do work well, but again, not 100%.
Well, I recall a couple years ago there was a big scare about this blindness thing going on. Is that
Great
something?
question. You basically, if you look at the data with the blindness associated with Viagra, and then you have to carry it on to the other two agents, if you look at that, it occurred in severe diabetics who already had visual problems.
Okay.
Some of the medicines in some patients will almost cause a blue hue to colors. The reason for that are the rods and the cones in the eyes and the way they metabolize the drug. I have not seen or come across any warning of a significant risk for that in the general population. So I really don't think that is a major issue. I mean, obviously, if I have a severe diabetic with all kind of problems, I'm going to have their ophthalmologist take care of that.
Right.
But I think that's, that was blown out of proportion.
I see. So personal injury attorneys stand down on this particular
Yeah,
issue.
I can't, I just can't see that being a big issue.
Okay. We did talk a little bit about, actually you talked a lot about overactive bladder in women. Just in case somebody's tuning in just a little bit late and catching the final end of this, just give them a little capsule summary of overactive bladder.
Overactive bladder, basically symptoms of frequency, urgency, and urgent continence. Once you understand the process, the majority of patients can manage it with behavioral therapy, dietary changes, and manage it without medicines. The newer medicines are very effective, minimal side effects, and you have to find the one that works best for you, but they are available.
Okay. And the medicines, again, as you said, for the most part, you can treat a lot of this without taking any medicine.
Yeah, I think it's once you understand what's going on, but they're there if you need them.
Okay.
And I think that really becomes a patient-driven decision. Is this, again, not to reiterate, is this bothering me enough that I want to go on pills for? And that, I think they have to make that call.
Let's talk, we got a few minutes left. Let's talk a little bit about the scary stuff.
Okay.
What do you do when you pass and you see blood in the urine?
Great question.
Not you personally.
No. Okay. That's that cherry Kool-Aid again.
Right.
What's called hematuria. Basically, no one bleeds to death through their urinary tract. So you need possibly to go to the emergency room to be evaluated if you're having problems, but you need to notify your doc. Basically, the evaluation of blood in the urine in a man and a woman to some degree changes as they age. Also, you have to look at risk factors. Again, we talked about smoking earlier with bladder cancer. Smoking increases other urologic cancers as well. Basically, typically what you do is when you evaluate that, certain types of kidney x-rays, scopes in the bladders, blood tests for prostates, and urines looking for potential infection or cancer cells. So that's pretty much a general mainstay of working up blood in the urine.
Okay.
Encouragingly, in the vast majority of people that walk into the office with either microscopic blood in their urine or gross blood in their urinary tract, we find nothing threatening.
Okay.
it is due to a benign condition.
Okay.
But just like if someone calls you and says, you
Right.
know, I was doing fine and I had blood in my stool,
Right.
you're going to recommend a colonoscopy and have that checked. It's for
Sure.
the same reasons, to make sure there's nothing threatening causing that problem.
Well, it makes perfect sense.
Sure. It's,
So,
you know,
so
it's
we're
just
not,
an
we're not
evaluation.
asleep at the wheel,
No, no, we don't want
You
it
know.
to have a problem. But encouragingly, the majority of people do not.
because we see these late night commercials. If you're the victim of delayed diagnosis.
Oh, yes, delayed diagnosis. Yeah, you have to
Delayed
like that.
diagnosis.
Yes,
Well, you
love
know,
those. I
sometimes
know.
we just, that's okay, Mrs. Snodgrass. You can, don't worry about that blood in your urine unless
That's
it's
right. Yeah, no, you
something
want
that
you
happens
want
every-
to check,
every
but
day.
don't panic.
Right.
It will be
Okay.
evaluated.
And if you have a runner, something like that, do you see these people with
Yeah,
microscopic
yeah,
hematuria?
basically exercise-induced hematuria. Again, you still have to check.
You won't see that in me, by the way.
No,
Just,
I didn't think
just,
so.
I want to let you know that.
Well, I've seen your golf swing. I could see where that would cause blood, but to the people playing with you, but that's a whole nother story. That's a whole, we could
That's
do
a
a whole half
different. I knew
hour on that.
You almost made it the whole game without talking golf.
right.
I knew it was going to come.
But, you know, the majority, even that, you need to evaluate, but people can have that. It doesn't mean you have to stop running, but you can still do that. But it needs evaluated.
I'm going to stop running just in case there's a chance I might get the
Okay, that's a
microscopic
good
hematuria. That would be where I would go with that
Okay,
particular issue.
that's fair.
Okay, to wrap up, why don't you give us a quick summary on urologic health? Who needs to come see you?
Basically, what you need to do is I drink a lot of water. You know, do your water, don't smoke. Beginning at 50. If you're a man, begin to get your prostate checked with PSAs and digital. If you're at higher risk for cancer or family history or black, get checked at 40. If you're having significant voiding symptoms, that needs to be checked. Basically, it's the same thing you tell patients. You know, take
Right.
care of yourself. Look for symptoms. You know, burning, bleeding are the ones I worry about. Guys go, what do I need to call you about? You know, blood in your urine, a lot of significant pain or burning that progresses with urination, or it becomes tough controlling your water or making your water.
Got it. Can't pee, see you.
Can't pee, see me.
That's right. Tim, thanks for coming
You're
to the
welcome,
show.
Gene.
Dr.
Thanks
Tim
for having
Weyrich,
me.
board-certified urologist, great friend, comrade, and
Scary.
potential golfer.
Potential.
And
Very
Coulter
potential.
move aside, Dr. Tim
Yeah.
Weyrich from West Virginia is coming to town.
Thank you.
If you'd like to get a hold of Tim, you can call the number on the bottom of the screen. You can watch us in replay. Please feel free to give him a call if you have any questions and or your family doc. As always, as we said,
Thank you, Gene.
behave yourself. Thanks for
Yes.
coming.
Thank you, Gene. Appreciate
And
it.
have a good evening. Drive safe. Yield to pedestrians. That's
Yes.
going to be my new,
Right.
because
Yield
I've
to
walked the
pedestrians.
town. Yield to pedestrians. You like that?
Yeah, I do.
Okay.
Thank you.
Have a good night and welcome. We'll see you next time. Thanks.